Good morning. Good morning. Am I audible, sir? Yes, yes, now. Thank you. So, good morning, everybody. It's a pleasure of coming here for this prestigious conference, SEO conference, which is a great event in terms of learning and sharing experience with each other. And I am indebted to the organizing team for inviting me to and giving this opportunity here. Big thanks to Mubarak Khan, Sapna and the entire DY Patil team for giving this opportunity once again. So thank you so much, and believe me, it's a great learning opportunity for me from the giants of endoscopic otology. From the giants of endoscopic otology, with the leader itself, Dr. Mubarak Khan, and the Muaz Tarabichi. I respect him from core of my heart and learned a lot of things from him in endoscopic otology, who has a vast experience, who is a global leader, and I'm sure we all are going to learn more and more from him in next 2 days. I'm amazed to see the facilities here at the DY Patil Center. This prestigious medical college, we all know, is a huge department, has a huge academic activity always going on. They have more than 24 residents in-house and many faculty and other members. You can imagine, and the kind of facilities here is simply amazing. So big thanks again for this opportunity to be here at this prestigious center. I hope you are getting microscopic picture there. इनका वॉल्यूम बढ़ाओ ना इधर आने का. हेलो हेलो. Yeah. Now. So this is a picture of the temporal bone. This session, as you expect in an otology workshop, to begin with more and more focus on anatomy, on basics, and to be here to begin this session with this temporal dissection, though microscopic. So I am like a foreign body in the endoscopic workshop here using microscope, but here not for any surgical procedure, but to share the anatomical details of this temporal bone with you all. We all know temporal bone is one of the most complex structures in our body. Out of any other bone in the body, this is most complex anatomy we all know. And the reason is not only what we see from developmental point of view as well. This bone is composed of 4 different bones, 4 different parts, and they unite at various parts which each other at various level, giving more than 34 suture lines. You can imagine how complex this structure could be. So the 4 parts, to be very simple, are the most lateral part. This entire lateral part of the temporal bone is formed by squamous part of the temporal bone. Whatever structure you see on the surface, all belong to squamous part of the temporal bone. Maybe this zygomatic root, maybe all this mastoid hair cell laterally, the spine of Henle, the part of the canal, everything laterally is made up of, is part of squamous part of temporal bone. And all deeper structures, all vital structures, including the labyrinth, is part of Peter's part of the temporal bone. Besides this, we have a very important tympanic part of the temporal bone, which forms the part of the circumference of the auditory canal and give rise to styloid process from beneath. And this is an important part which completes the auditory canal and unites with the other parts of the temporal bone at various levels. Like it joins the squamous part forming a squamotympanic fissure, laterally the lateral fissure, medially medial fissure, joining the Peter's part at various levels, joining the, various parts. And in the depth, the 4th part is the styloid complex. Dr. Professor Tarabichi is going to illuminate us the anatomy of the middle ear. And for us, the very, very important part of the middle ear is the retrotympanum. Retrotympanum is the posterior part of the mesotympanum, which is bounded behind by the facial canal. And that part has a very, very important anatomy with various structures like ponticulus, subepulum, round window and the round window recess and so many things. All those areas belong to the styloid complex, styloid eminence. All those eminence of the chorda, pyramid, all those belong to the styloid eminence. So that's the fourth part of the temporal bone in the depth, and that joins all parts of the temporal bone all together at various levels. So that's how the temporal bone is formed of these four parts joining at different levels, forming more than 34 suture lines. They have clinical significance as well. As in children, sometimes these suture lines are not ossified and there remains a space, an avenue for the infection to spread to the intracranial space, and that's why in children even a simple episode of otitis media can be lethal, can give rise to meningitis and further ascending infection. So understanding this anatomy is very important, and today in this conference, Dr. Mubarak Khan and Sapna have kept variety and different situation of cochlear implants. So we have number of cases of cochlear implants. So here I will focus on the anatomy of the inner ear, which is considered to be complex otherwise, to simplify it for the cochlear implant surgeons. Being cochlear implant surgeons, we must know in-depth anatomy of the cochlea and vestibule, or I would say the entire labyrinth. So here today I will focus on the in-depth anatomy of the labyrinth as well. Laterally, we all know the structures. What we see here on the surface is the extra-auditory canal. In the depth is the tympanic membrane, which is looking ruptured. Here is the mastoid, which is not a portion which is present at the time of birth. It is formed after birth with the fusion of squamous and the petrous part of the temporal bone. So whatever we drill laterally is going to be the part of the squamous part of the temporal bone. I am going to dissect quickly all air cells in this mastoid bone, showing you the limits. This is the very, very basic part of any temporal bone dissection. And see here, for junior colleagues, our limits are very well defined if you follow on the lateral surface of the temporal bone. Superiorly, see, this temporal bone is situated underneath the temporal lobe of the brain. Above is the temporal fossa of the brain, the middle cranial fossa above, and this is separated by the thin bone. This is the thin bone which we'll see inside is the tegmen, which forms over the antrum is the tegmen antri, and on the over the middle ear the atic is tegmen tympani. So this tegmen is roughly corresponding to the, if you follow this root of the zygoma as the inferior temporal line, is a great landmark. Great, I would say not only great, but as a safe landmark, because the actual tegmen is couple of millimeters above this temporal line. So if you follow this temporal line as a landmark, your tegmen remains a couple of millimeters above and you are pretty safe, not damaging the tegmen at this level at the beginning of the surgery. So follow the root of the zygoma, see the air cells coming. These are the air cells, and this is a great safety landmark. Great safety landmark. See, this is the root of the zygoma, still air cells are above, and the actual tegmen is couple of millimeters above. So for the junior colleagues, once they are dissecting the mastoid, they can take the reference of this inferior temporal line, the root of zygoma, and still a couple of millimeters below the level of the tegmen. See how tegmen is little higher up. Let me show you. See, almost 4 to 5 millimeter below the level of the actual tegmen tympani. So that's a great safety landmark if you follow this temporal line. Let me actually show you the tegmen, that how superior it is in this particular case from the zygomatic line. More the mastoid is pneumatized, more this is going to be higher up. That is the level of the tegmen. That is the flat bone, that is a thin bone tegmen coming here. And look at the level of the zygoma. Can you appreciate this? So when we consider for mastoid dissection, we can consider this zygoma as a very, very safe landmark. Secondly, one of the important relationship of this mastoid process underneath is the sigmoid sinus. Again, to stay on the safer side, sigmoid sinus usually is a posterior structure, a little deeper structure. It is never, it can be, in unusual situation, it can be dehiscent and lying even on the lateralmost part of the cortex sometimes. So what you can do after this tegmen, after this zygoma or zygomatic line, you can take the reference of the circumference of the extra-auditory canal. यार ये बड़ा दे यार. Give me a bigger section.
मूवमेंट के लिए स्विच दिया हुआ है. नीचे स्विच दिया हुआ है मूवमेंट के लिए आपको. ये वाला मूवमेंट और ये वाला.
अच्छा switch है.
हाँ स्विच है.
Waiting for the section. So yes, centralize. Okay, okay. Is that fine?
Yeah.
Sir, feel free to interrupt me at any point of time, please. Anybody from the audience, please feel free to interrupt me. So my second reference line I am taking is the circumference of the extra-auditory canal. My sigmoid sinus, see, sigmoid sinus is formed as a continuation from the transverse sinus behind and continues in this mastoid process as a posterior limit. So, it can be little superficial sometime, but mostly it is little deeper, particularly in the more pneumatized temporal bones. So once you take the reference of the extra-auditory canal and the reference of this tegmen, you can go behind and in the depth to discover the sigmoid sinus in the safest manner. See, I am going behind and in the depth so that I can discover the sigmoid plate. Here I am working on a temporal bone, not on a cadaver. So the sigmoid sinus plate is going to be a thin plate of bone separating from the posterior cranial fossa. See how pneumatized this temporal bone is. More it is pneumatized, more it is favorable for dissection point of view and for understanding the anatomy. See how pneumatized. All these are, now see I am in the vicinity of the sigmoid sinus region. So all these are perisinus cells. इसको काट देना यार. All these are perisinus cells which I am dissecting. See, all these air cell tracts are very important to understand and assessed on a temporal bone CT scan before, once you are contemplating any bigger procedures like subtotal pintorojectomy and all that, which requires exentration of all cellular tracts. All these cellular tracts are aerated down the Eustachian tube. So we must know all cell tracts once you contemplate any major procedure like subtotal pintorojectomy. We have a case of subtotal pintorojectomy in this conference as well, wherein we'll discuss how one can exentrate in toto all these air cell tracts by understanding their anatomy on a temporal bone CT scan and follow them and track them. See, all these cell tracts, all these are cell tracts, all these are perisinus cells. It is very important to uncover them, exentrate them, as these cells can contain mucosa. So in subtotal pintorojectomy, aim is to exenterate the mucosa. If you leave the mucosa behind, it can give rise to problem, and the problem may continue forever. See now in the depth, the change of color. Can you see the change of color? This is the sigmoid sinus. See, there is a thin plate in the temporal bone. You can appreciate. Very, very thin plate. Now, to complete your cortical mastodectomy, we have limits all around. In cortical mastodectomy, we are supposed to exenterate all these hair cells. Our upper limit is the tegmen, as we discussed. This is here. That is the tegmen tympani, tegmen antri here. Posterior limit is roughly the sigmoid sinus, and if there are perisinus hair cells, we have to exenterate them as well. Start this one. At this level from behind, the transverse sinus continues as sigmoid sinus. And in the depth here, it joins a tributary. It joins a sinus, venous sinus, that is superior petrosal sinus at the level of the superior surface of the petrous bone. See, above is the brain. So here is the superior surface of the petrous bone, and on the superior surface of the petrous bone here, a sinus runs which connects the cavernous sinus to the transverse sinus. And at the junction beyond, the transverse sinus continues as sigmoid sinus. So actually this sinodural angle refers to the joining of the superior petrosal sinus to the transverse sinus. That is sinodural angle in the depth. It is not the surface sinus anatomy joining the dural plate. See here this angle, that is lateral surface, and in the depth, this is the sigmoid sinus. I am exentrating all these pre-sigmoid cells. Can you see this? Thin plate of bone and exentrating all these pre-sigmoid cells. Now you can see our landmarks are becoming more and more clearer. This is the flat tegmen bone. There is the region of the sinodural angle, and this is the sigmoid sinus running down and deeper. And here we will see in the end how it forms the jugular bulb. And then continues as the internal jugular vein. So now, superiorly this tegmen as our limit, you can see very clear. Posteriorly this sigmoid sinus as our limit. Anteriorly is going to be the labyrinth. See now, this is the extra-auditory canal which I am thinning and thinning. Thinning and thinning. And see what is opening there? I can see the thick bone in the depth. See that? That is the semicircular canal. Can you see the lateral semicircular canal in the depth? See this thin, this ivory white bone. Can you see? Yes. That is the part of the labyrinth. That is the part of the labyrinth. And in between these three structures, means labyrinth anteriorly, the sinus behind, and the dura above. If I exenterate all these cells, this area is the Trotman triangle. Why it has been defined like this has a clinical significance. See the labyrinth, thick bone anteriorly, can you appreciate? Yes, this labyrinth is composed of various semicircular canal and the cochlea anteriorly. So between the labyrinth, the tegmen above, see here the flat bone, the thin flat bone. Yeah, I have also. And here, so if I keep drilling these cells here, you can reach to a thin plate of bone, and if you go through that bone, you reach directly onto the cerebellum. the posterior cranial fossa. So this was initially described to drain the cerebellar abscess from here, reaching out the cerebellum from the temporal bone, from the mastoid, is through the Trotman triangle. I hope it is clear. See, all these air cells I am quickly to save time so that we can focus more on important areas in the depth. Now, inferiorly, this is the region of the Trotman triangle. I need to accentuate some more cells here. My labyrinth is coming anteriorly, the sigmoid sinus behind, and the tegmen plate above. Now, inferiorly, if I focus a bit inferiorly, see, this temporal bone projects like a process below. This is mastoid process.
Yes.
This is mastoid process which contains numerous air cells. And if I drill away this mastoid process more, you can get to know some more important anatomy. Very, very reliable anatomy you can get to know for the facial now. See, let me accentuate, hollow out this mastoid process. I am hollowing out this mastoid process. We all know outside the mastoid process, outside are various muscles attached on the mastoid surface.
Yes.
From outer to inner surface, from lateral to medial, the most lateral muscle is sternomastoid. Medial to that are the semispinalis capitis, the digastric, and the oblique muscles down the line. So, here the digastric, where the digastric is inserted, it makes a landmark, the digastric ridge, which you can appreciate from inside. And that's a very, very important and one of the most reliable landmark God has given us for some anatomy. See here? See how pneumatized this mastoid process is. So I am hollowing out this mastoid process thoroughly. And now focus on a very, very important landmark. Once I accentuate all these cells, here, this is the area here where the digastric insert.
Yes.
Let me clear it. And it gives a good horizontal ridge. And this is better appreciated when there is a muscle outside or in a live situation. Can you see this horizontal ridge?
Yes, sir.
This is digastric ridge where the digastric muscle is inserted outside. If I follow this ridge anteriorly, this will take me to the vertical portion of the facial canal. The vertical portion of the facial canal corresponds immediately anteriorly where this digastric ridge ends. And the same anatomy we extrapolate in the parotid surgery from outside. In parotid surgery outside, digastric is one of the greatest landmark to follow the facial nerve exiting the stylomastoid foramen. So how the stylomastoid foramen is? Mastoid process laterally and the styloid process medially here. And in between there is the foramen through which the facial nerve comes out. And at this point where the facial nerve comes out, the digastric is immediate inferior structure. So this digastric is a great landmark given by the God. if we follow this ridge, we will find the facial nerve, the lower vertical portion of the facial nerve. Keep in mind this facial digastric ridge. Okay? So for facial nerve is one of the most important structures traversing through the temporal bone. And it has a serpentine course like carotid artery, which also traverses through the temporal bone in a parallel fashion, parallel to facial nerve. So the facial nerve has various landmarks for various levels. Like, to just begin with, I will show you the entire course of the facial nerve as we dissect this bone. So in the depth is the, deep to this labyrinth is the intra-auditory meatus, from where the facial nerve ascends as a small segment, like my instrument is pointing, exactly laterally like this, from the intra-auditory meatus for a couple of millimeters as a labyrinthine segment. Here in the anterior attic, this labyrinthine segment turns almost 135 degrees back and continues as a horizontal segment. Then at this level of the anteromedial circumference of the lateral semicircular canal, it has a second turn, second genu, which is obtuse more than 90 degree and turns vertically down. So at various level, and it continues down extratemporal through the stylomastoid foramen. So at every level there are certain reliable landmarks to identify and preserve the facial nerve. For labyrinthine segment, this anterior attic is a landmark. And what emerges from there as it takes the first turn, first genu, is the GSPN. GSPN emerges, I will show you, and goes far anteriorly. That is the greatest landmark. And behind that is the superior semicircular canal, which I am going to uncover very soon. Then this horizontal segment underneath the incus. See this incus? This incus covers the facial nerve, protect the facial nerve like mother's lap. So all the way incus is lateral to the facial nerve. In otology surgery, as long as your incus is there, your facial nerve is automatically protected underneath. Then here at the second genu, it is closely related to the lateral semicircular canal. Then in the vertical course, it is lateral to the posterior semicircular canal. I will uncover and show you. And then at the stylomastoid foramen, it is immediately related to the digastric ridge. That's how the facial nerve is related to various parts of the temporal bone. So let me uncover the facial nerve at a very, very important segment. This is vertical segment. See, this canal is intact. Nowadays, we all know the cochlear implant procedure has emerged out as a boom to rehabilitate the profound sensorineural hearing loss. Age is no bar. Initially, it was devised for children, young children, born deaf, to rehabilitate with the cochlear implant. But nowadays, age is no limit. Any person, child, adult, maybe 90-year-old, maybe 9-year-old, maybe 9 months old, any patient having profound sensorineural hearing loss, where the hearing aid is not benefiting, cochlear implant is indicated, as simple as that. So, one of the most important approach, the commonest, the traditional approach for the implantation is the posterior tympanotomy. What you need to do in that, you discover the retrotympanum. I am sure Professor Tarabachi is going to show us in-depth anatomy of the retrotympanum later. So, in the retrotympanum, we approach the round window from the mastoid side by making an entry lateral to the facial nerve and medial to the annulus. That small triangular space is a key to approach the retrotympanum from behind. And that is the most common approach for the cochlear implantation, as it is considered to be very safe. And that's why it is most commonly used. So, what are the landmarks for that? See, that's a triangular space underneath the annulus. If you breach the annulus laterally, you will enter the extra-auditory canal and violate the entire, field. So we are not supposed to do that, and we have to stay underneath the annulus, and that is corresponding to the chorda tympani, which runs immediately underneath the annulus. So my lateral limit for that triangular space is going to be the chorda tympani, which is a great reference to the annulus. I mean, the annulus is immediately lateral to that. So as long as you preserve the chorda tympani, you preserve the annulus as well, and you don't go far laterally. Similarly, medially the facial nerve, and that part of the facial nerve, that is the vertical segment of the facial nerve. So in order to identify and protect that part of the facial nerve, there are certain landmarks which you can consider on a safer side. So let me show you. First I am thinning out this canal more and more to, give an appropriate angle in the depth of this canal. See the depth of this canal. We are drilling in the depth of the canal. Now my biggest landmark which I consider, yes sir. Biggest landmark, as I mentioned, is the incus. Incus covers the facial nerve from laterally, and at this point, this is the lateral semicircular canal, this is the incus. If I run my drill and dissect parallel to the incus, if I run parallel to the incus, my facial nerve is always medial to it. Simple. See what I am doing? I am running my drill parallel to the incus, simplest way. As long as I am parallel to the incus, in the depth of the canal, I am pretty safe. The facial nerve lies in the circumference, anteromedial circumference of this lateral semicircular canal. Anteromedial, and here even I am lateral to the canal, but parallel to the incus, leaving a small bone where the incus insert into the fossa incudis so as not to destabilize the incus and giving a further unwanted ossicular chain motion. So here I am working in this space and I can see some important structure here for everybody. Let me zoom in. Let me zoom in and show you. Yes. Is the picture clear? Hello? Clear now? See, I am running parallel to the incus. Very, very important point for everybody. And can you see the thin whitish structure running parallel? Yes. That is chorda tympani. This chorda emerges from the facial nerve here medially and then goes laterally towards the mesotympanum to run above the incus and medial to the annulus. Can you see the glimpse of the chorda here? Yes, sir. Now once you see the chorda, your facial nerve is going to be medial to that, and you have to be running your drill immediately parallel to it. Excentrate wherever you find the cells. Excentrate, keep excentrating the cells. Keep excentrating the cell and see the change of color now. See the change of color. Can you see the facial now?
Yes, yes.
Very clear or not?
Yes, absolutely clear.
This is the facial nerve coming. Can you see?
Yes, sir.
Diamond. Now once you see both the nerves in vicinity, I just wanted to show you the exact location of this triangular space. See, there are people who are not identifying the facial nerve positively and using indirect landmarks. Indirect landmarks can be dangerous because this course of the facial nerve can be variable. Sometimes it is little more lateral, sometimes it is little more posterior or anterior, and your pre-operative CT scan can tell you exactly. See now again, both the nerves. Can you see the chorda tympani anteriorly?
Yes, sir.
And see the facial nerve behind. Ek side chota. See, this cells is being opened up. This triangular space. This, see how far I am from the incus.
Yes, sir.
So I have ample of space to extend it superiorly as well to make it bigger. Yes, please. Can you see something?
Yes, sir.
The opening made from behind, staying lateral to the facial now. See, positive identification of the facial now makes your life so good. You know where you are not supposed to go. You can keep the facial nerve in field and keep drilling. See this? So you can give the widest possible posterior tympanotomy.
Yes.
At the same time, my anterior limit, you can see the chorda in view. And see, I am drilling the anterior border of the facial nerve to widen my posterior limit tympanotomy to biggest. Let me show you how big the posterior tympanotomy. And the interesting fact is, there are certain, parts of the temporal bone which do not grow after birth. Whatever middle ear, inner ear we see at the time of birth is of same size which is in adults. It doesn't grow at all. Similarly, this facial recess is of same dimension in adults what it is at the time of birth. It never grows, and that's the biggest advantage in posterior tympanotomy approach to the cochlear implantation. Even in the youngest of the child, the dimension of the facial recess remains same. It doesn't change. What all changes is the dimension and curvature of the extra-auditory canal, not the facial recess. Can you see the retrotympanum from here?
Yes, sir.
I can see the glimpse of the round window as well. Immediately superior to my section, I will show you, clean it and show you later on. Now see what I have done. See, I am staying medial to the chorda tympani. I can see my chorda tympani all the way in my, anterior limit. Yes?
Can you, what are the other indications for this facial discomfort other than CI?
Yes. In chronic ear surgery as well, some time for aerations, while doing tympanoplasty or so, we have a practice of ensuring the aeration of the mastoid air cells down the Eustachian tube. And there are certain situations where the anatomical abnormalities prevent you from reaching out to the mastoid antrum so easily. Because of the narrow space, because of the, downsliding tegmen, because of the many other anatomical abnormalities, that reason. In that situation, one of the way for the aeration of the mastoid air cells is through the posterior tympanotomy. So you can utilize this as well.
Anytime you use it for globus,
Tympanicum, yes. There are, glomus means paraganglioma. So paragangliomas arising from the tympanic plexus, they extend to involve the hypotympanum, they extend to involve the mastoid as well. And in those situations, according to the extent, you can plan your surgical approach. Like for example, silent. If the paraganglioma is limited to the promontory, you can remove transcanal. If it is going to the hypotympanum, you can do the extended approach by means of drilling the hypotympanum, or you can come from behind and do an extended posterior tympanotomy. Extended posterior tympanotomy means then you sacrifice this chorda and keep drilling this bone to expose the hypotympanum completely. And that is one of the preferred approach in that scenario, rather than unnecessarily giving a canal down approach for that patient. So it is a versatile approach to give you, extensions or exposure of the hypotympanum. At the same time, you can remove the mastoid part of the paraganglioma from behind as well. So there are number of indications depending upon the, situation, depending upon the need. Now, if I tilt my instrument, the bone behind, can you see something through the posterior tympanotomy? Superiorly. Let me, yes. Can you see something to the posterior tympanotomy superiorly? Pick. Let me show you. Yes. बंद है यार, पतला दे अभी, पतला से एक साइज पतला. Yeah, let me show you. See, this is your facial canal. Can you all see clearly?
Yes, absolutely.
Immediately deep to the facial canal, here is this pyramidal eminence.
Yes.
See that pyramidal eminence, very clear. Now it is very clear.
Yeah.
This is pyramidal eminence from which the pyramid is emerging.
Can you zoom inside, sir?
Yes, I will. And can you see the tendon emerging from it? Can you see this?
Yes.
That is stapedial tendon.
Yeah.
So this is pyramidal eminence. This is stapedial tendon. This should be your superior limit to the posterior tympanotomy. To know where exactly you are, to see the ossicular chain as well. Here the incus is displaced. Otherwise you can see the long process of the incus through it. You can see the long process of the incus through it. Here and the stapes below. Here is the stapes. Can you see the stapes?
Yes. Yes.
Mobile stapes. So this is my superior limit. Now,
Can we see the stapedius muscle also?
yes, not very clear in this scenario, but yes, you can see the stapedial muscle and you can see the stapedial reflex at the time of cochlear implant. You can stimulate and see the stapedial reflex very clearly from here. That's the stapedial. The muscle actually is a very small portion coming from the cone of the pyramid. The muscle inserts inside the surface of the pyramid and comes out as a cone and then continues as a tendon. Very small muscle supplied by the facial nerve. So this is our superior limit, okay? And this entire bone forming the fallopian canal, this caudal eminence, the cauda is emerging from here. Yeah, yes. This caudal eminence where the cauda is emerging, this pyramidal eminence where the pyramid is emerging, and see this is ponticulus here. I will show once I go into depth. And this fallopian canal continues down as a stylomastoid foramen. All these structures belong to the styloid complex of the temporal bone, the fourth developmental part of the temporal bone. Now, coming to the different angle now here, I am tilting the temporal bone further behind. See, below this pyramid, that's a great landmark so that you do not disorient it. One must see the pyramid and then focus below the pyramid. Can you see this bony eminence?
Yes.
And underneath this eminence is the round window. Can you see?
Yes, sir.
That is the round window. This is the back door, I can say, when we enter into it, back door entry into the cochlea. And this bone is variably thick. This bone forming the niche over the round window. Can you see? The round window is partially hidden.
Yes.
This is round window niche. And you need to expose the round window. One can drain the round window niche. How much the round window is going to be exposed, how thick is going, this niche is going to be thick, you can predict from the pre-operative temporal bone CT scan.
In the real time, you use the same bone or you have any taper cut burrs for this?
Same bone or?
Taper cut burrs to prevent the injury of the shaft to the.
Yes, yes. So as you go deeper, can you see my burr point? Can you see? These are long tapering burr points. Can you see this? Your point is very, very valid and very important at this point. We should use such long tapering burr points to protect the facial nerve from getting injured. See this? I have exposed the round window more and more. Quick, go the round right angle. Right angle.
The risk of the injury to the facial, is it real or it's more of a theoretical? You had any?
Yeah, the shaft can injure. That's why to prevent that, number one, we should keep a very thin piece of bone over the facial nerve. Number one, we should skeletonize the fallopian canal, but still leaving a very, very thin, papery thin bone over the facial nerve. Number one. Number two, we should use long tapering burr shafts so as to protect the facial nerve. At the same time, the shaft doesn't come in the view as well. So these are important burrs. You can see the round window very clear. As I told you, I am going to uncover the entire anatomy of the inner ear thoroughly in detail. This round window is one of the greatest landmark. In cochlear implant surgery, from the round window approach, you are not supposed to do anything more than that for the exposure. People go through the round window, people go through the cochleostomy. We will discuss in detail why this fight is unnecessarily going on. No point in fighting that. The only thing required is we should have a straight shot insertion in the scala tympani. Straight shot insertion, if it is afforded by the round window itself, it is fine. If the lower lip of the round window bone is coming in the way, you need to drill it off to make a straight shot insertion. Got my point? Our implant should go straight well in the lumen of the scala tympani of the basal turn of the cochlea. It should not hit here and there to give unnecessarily intracochlear damage. That is the key in preventing intracochlear damage. So what I am trying to show you, let me open the round window. See the round window I am removing? Well, drill there, no? Yes?
Khan sir wants to talk for just 1 minute.
Yes, yes. Yes, Mubarak, you can take the camera for whatever time you want. Mubarak wants to show something.
Yeah, he picture is there already. So, Dr. Mubarak? Hello, Dr. Mubarak?
बॉस एक पेपर और पेन मिल जाएगा क्या इनको बोलना पैड और पेन राइट एंगल देना
Yes. Yes.
I hope picture is good. Picture is good.
Image is not, hello, brain image is not seen. Main screen is empty.
Hmm.
Can you please start
किधर है? Hello man, how are you? क्या चल रहा है आजकल? अच्छा. Good, good. अरे good, good.
देखा कॉलेज
Hmm.
your plan is to keep the graft below the handle or above?
बस
Above the handle.
Yes.
मेरा जैसा जमा मैं ओटी में भी आता हूँ फिर।
आ जाओ ना
कल भी है और आज
हाँ हाँ
Yeah.
देना देना देना
Can you just
ये डालो
show once the external picture of your endoscope and everything?
Can we see the perforation?
मुबारक सर मुबारक सर
Can we see the perforation?
No, no, not yet, sir. Yeah, can we see now? External picture is seen.
Yes. So you can see that it was for holder. I will demonstrate later on how we attach that. And then we do the component. So it's not just like a holder, it's a dynamic holder because it keeps on moving here and there. I see I can go in like this, I can go in here, I can come out. Okay? So this is with this fine focusing of my endoscope holder.
Okay.
So you can't hold of fixed vision. So the scope is needed for the your surgery. You need to get many instruments. Carry a super-handed endoscopic your surgery. Can you see now the perforation?
Yes,
The scope is 3 millimeter. This is 3 millimeter. Yes. For the police control, I will use the 4 mm. I will be doing it with the next case. The afternoon. Okay. So, plan is just to the type 1 tympanotomy, which will go on in feet. So, whenever you want to see certain things, you can go. Yes. Yes.
can the picture be more clearer than this?
Yes, come again. You want to because I think that's
ये रिकॉर्डिंग स्टॉप करना
and
आजाद वो है वो
हेलो हेलो हेलो
hello, yes, sir, we are with you.
Okay, so great going, Mubarak. Superb. So what you see in front, in the center is the round window. Can you see very clear now?
Yes, sir.
After drilling this round window niche, you can see the standing out round window. Now the question is, which to me is an unnecessary debate. What approach one should use, a round window, cochleostomy, peri-round window, whatever. See, the goal is to have short in our implant should go in the straight inferior tunnel, that is scala tympani. Now, what anatomy gives you that straight short insertion one should use? Like for example, if I go through the round window here, see this. I open up the round window here. See the scala tympani. Can you see very clear?
Yes, yes, very clear.
This is the dry piece, so see the membrane got dried up. Forceps. See now, what you see in the depth is the modulus. That is the modulus. Let me clear it. Yes. Now?
Clear.
Okay. So I have opened this round window to show you inside the scala tympani. See the scala tympani?
Yeah. Clearly.
What you see in the depth?
The spiral lamina?
No, I'll tell you what a spiral lamella is. This is modulus. So if I insert my if I insert my implant through it, see this. If I insert my implant through it, it's going to go and hit the modulus first. Can you see the modulus there in the depth?
Okay.
So this is going to hit the modulus. If I go my straight with this approach to insert my implant. So how to avoid? Where is the tunnel? Let me turn it. Let me turn it from superiorly. Can you see the glimpse of the tunnel? See the tunnel going in the depth. Can you see? So in order to make this tunnel more straight, what I can do simply? See, this inferior ledge of the round window is coming in the way. Can you see this? I am drilling simply this inferior ledge of the round window. Only inferior one, not medial one. Never drill the medial one. There are certain important structures in the medial wall of the round window. Can you see the opening much better now?
Yes, yes.
This is the straight tunnel now. You can push your implant under vision without any issue. Panda. Look at the straight tunnel. Just drilling the small lip of the round window, inferior edge of the round window, I can see, I can focus in the depth of the tunnel. See the depth of the tunnel. Give me wash. See the deep three-dimensional tunnel. Abhi ruk gaya.
This cochleostomy versus round window insertion. I mean, we are drilling more of the cochlear bone than what about the...
Yeah, we are just drilling the, can you see the tunnel in the depth? So here, this is the inferior tunnel.
Can you focus on the nail exactly?
Yeah. Inside. See this tunnel. Once I open up the cochlea, you will see all the three canals. The scala vestibuli, scala tympani and the scala media. This is the inferior tunnel which is called as scala tympani. This contains perilymph and this is in the closest proximity of the modulus, which we want to stimulate the hair cells. Can you see the tunnel very clear?
Yes, absolutely.
So this is separated from the other two canals by the osseous spiral lamella. I will show later. So this is the inferior tunnel and our aim is not to hit the implant directly to the modulus, but rather inserting in this straight tunnel. How this straight tunnel is made? By removing the inferior lip of the round window. Got my point? So no debate on cochleostomy. See carefully. This is the tunnel. And if I tilt superiorly now again, what is there in the depth? This is modulus. Can you see in the depth?
Yes.
This is modulus. And if I tilt it inferiorly, see, keep an eye.
Canal is same. Yeah.
Yeah, that's the tunnel. See that?
Yes, sir.
So idea is to make this three-dimensional tunnel as a straight, for the straight insertion. If I hit my implant, suppose, if I don't make this tunnel, we have a cochlear implant case after this, live case, I will show in that case as well. See, that is the modulus. Can you see the wall of the modulus?
Yes. Yes.
Wall of the modulus, and if I tilt inferiorly is the tunnel. See that?
Yeah.
So if I don't drill this bone, my implant will hit directly onto the modulus. See this modulus?
Yes.
If my implant hits the modulus, it will keep hitting the walls and keep destroying the cochlear structures, which are very, very thin, flimsy, and gives highest level of intracochlear trauma. Similarly, if I remove this inferior wall, see this, and turn inferiorly, this is my tunnel. One can easily understand the value of removal of the inferior wall of the cochlea. Can you see?
Yes.
This is very clear. It should be very clear. And this is one of the most important part in the cochlear implant surgery to avoid the intracochlear trauma. This is the wall of the modulus. And if I tilt it, this is the lumen. Can you see here again? Because this lumen is directed antero-inferiorly. And in order to reach out antero-inferiorly, you just remove the inferior lip. Now what I am trying to say again and again, this is the inferior lip which I have drilled. Can you see this?
Yes, sir.
This is the inferior lip which I drilled. We are never supposed to drill the medial wall here. In the medial wall of the round window, within a fraction of millimeter distance from the round window insertion, are certain important structures. One is the outer opening of the cochlear aqueduct. Cochlear aqueduct here opens here in the medial wall like this. A very thin opening. This is the outer one, and the inner opening is medially down in the posterior cranial fossa. So that is a fraction of millimeter away from the round window insertion. So we are not supposed to drill the medial wall at all. Similarly, the number of inferior cochlear veins are parallel to the cochlear aqueduct here in the medial wall. In the medial wall. So in medial wall, we are not supposed to do anything. This medial wall is very, very important. What we are supposed to do is remove this inferior wall safely. I hope it is very clear. And give this straight shot insertion in the lumen. You can see the lumen with the fluid inside. Can you see?
Yes.
And if you tilt it superiorly, if you don't remove this, what is there? This is modulus.
Yeah.
Once I discover the anatomy, further uncover the cochlea, you will see the modulus is the central core of bone, and all three cochlear ducts, scala tympani, median, vestibuli, are running around the modulus to make 2 and 3/4 ton. Okay?
Yes, sir.
So this is one avenue, the scala tympani, which is entered through the round window. That is back door entry into the scala tympani. Okay?
So direction of putting the even implant is also important.
Yes. Take a straight tunnel and then under vision put the implant in the lumen of the straight tunnel. So it doesn't hit the walls all around. It doesn't hit any of the wall all around. Okay?
Antero-inferiorly.
Yes. Now, beyond this, we have seen the facial now. We have seen the incus. We have seen the posterior tympanotomy. Now I am going to remove this canal wall to uncover quickly. Our given time is 2 hours. And I have to uncover the cochlea and vestibule very quickly. Understanding this inner ear anatomy is key to neuro-otology and skull-based surgery, or lateral skull-based surgery, and important otological procedure also, including the cochlear implant. So now I am removing this canal wall. See this?
Yes.
To be little crude, staying little quick. See this? Then body wali de wo conical. See this? The more and more promontory coming into the picture. Can you see? That is the tympanic membrane which I am removing. In subtotal petrojectomy, you remove all skin and mucosa from the temporal bone. And you block off all connections of the temporal bone from exterior. Exterior means you block off the Eustachian tube, which is the external connection through the nasopharynx. This is the Eustachian tube. Can you see there? Can you see the Eustachian tube? This is cochlea. This is basal turn of the cochlea. And here anterior is Eustachian tube, and in the medial wall of the Eustachian tube where my section is the carotid artery. Carotid artery lies in the medial wall of the Eustachian tube in close proximity to the cochlea anteriorly. This is your incus, can you see? This is your incus behind, and the malleus anteriorly. See, this is the incus, the malleus, and the stapes medially. So I have removed the incus. Now let me quickly remove this bone to reach out to the inner ear fastest.
Half an hour prior about to be done. Can you tell us? We'll start induction of that problem.
Okay, okay, sure. So I am removing now this root of the zygoma. What I am drilling is the root of the zygoma anteriorly, which forms the outer wall of the atic. Can everybody see? The outer wall of the atic. See, the atic is coming into picture. Atic is coming into picture, and the outer wall of the atic is formed by root of zygoma. This is formed by the squamous part of the temporal bone. So I am drilling away the root of the zygoma to uncover more and more atic. See, the posterior part of the atic is uncovered. And very important point here, you have to follow the curvatures of the tegmen. This tegmen, as you go anteriorly, most often it goes inferiorly. And it is dangerous. See, more you go anteriorly, the tegmen goes more inferiorly. Can you see? So be careful while going anteriorly, the tegmen might come in your way as it comes inferiorly, and one can damage the tegmen if you are not careful. There are various curvatures of the tegmen. See this. This part of the tegmen superiorly, this part of the tegmen laterally is more inferior. Can you see? And this part of the tegmen medially is more superior. Can you see? These are various curvatures of the tegmen. You can make out all these very, very clearly from a pre-operative CT scan, which we'll discuss during live surgery. So you can have a fairly good idea of the curvatures of the tegmen before operating on that particular patient. So these are important to prevent complications. And a CT scan is the best guide. I will show on CT. See, I am more and more removing the root of the zygoma to reach the anterior atic. Can you see? I will flush it. I will flush it to the anterior wall of the mesotympanum. See how the root of the zygoma is so pneumatized. So these are the part of the air cell tracts extending into the root of the zygoma. See the curvatures of the tegmen. Pardon?
What are the commonest types of traumatic CSF leaks in this area?
Yeah, tegmen. Tegmen is the commonest. Obviously, it separates from the middle cranial fossa. And wherever the tegmen is thin or dehiscent, it depends on person to person. But yes, this anterior tegmen is more thinner, and that is more common for spontaneous CSF leaks. Now see this anterior wall of the atic, I am flushing with the anterior wall of the mesotympanum. Can you see? this is the part of the, yes. And I am following the facial nerve here. See this? This is your lateral canal, and this is at this point of time, you can see variety of structures coming in your way. You know, you can visualize various structures now much better. I remove this part of, this is the part of the tympanic bone. This is the part of the tympanic bone forming the hypotympanum, the lateral wall of the hypotympanum, lateral wall of the jugular bulb. All this is tympanic bone I am thinning out. Can you see? In canal down mastoidectomies, when you do a wide meatoplasty, to allow the hypotympanum to drain in the cavity, we must remove this part of the tympanic bone and flush with the mastoid cavity. Can you see like this? This is a very, very important part to give a dry mastoid cavity. Very, very important step. This hypotympanic bone, this is tympanic bone, has to be flushed with the mastoid cavity, the medial wall being the fallopian canal. See, until the fallopian canal I am taking it down. Can you see very clear? Yes, see this is my digastric ridge. See the digastric ridge and the fallopian canal. This was the digastric ridge coming, and this is going right to the fallopian canal. Here is the fallopian canal. What an amazing landmark.
How many times in the open cavity you do a removal of mastoid tip?
See, if it is pneumatized, it should be removed. It's like in this case, what I have done is classical open cavity. See this? If you are doing a mastoidectomy, the important part is drill away this tympanic bone to drain the hypotympanum in the cavity, number one, and drill to the level of the fallopian canal, and here excavate this mastoid, the process, and see the facial ridge. Now more importantly, when you do a, and if you do an open cavity, remove the mastoid tip rather. If you remove the mastoid tip, you allow the neck muscles to fall into the cavity to, yes, to finally further, reducing the size of the cavity. Scissors, kuch dena kaatne mein. So this is important. Hi, Professor. We have Professor Muaz Tarabichi with us in the dissection hall. Muaz, we were discussing about the anatomy of the retrotympanum, which you are going to demonstrate. So I am not focusing on the anatomy of the retrotympanum, which we are going to again learn from the master today, Professor Tarabichi, who is going to demonstrate us with the endoscope. See now, this is your stylomastoid foramen. I am uncovering this foramen. Can you see how the facial nerve is leaving the temporal bone?
Yes.
And this is the mastoid tip I have removed. So this nerve leaves the mastoid at the level of stylomastoid foramen, and this digastric ridge is one of the, I would say most reliable landmark for the facial nerve at this region. Okay? So there are, as I told you, there are various landmarks for the facial nerve at various places. Now, at this point, before going to the inner ear, let me show one of the important anatomy here. This mesotympanum, this lower part of the mesotympanum or the hypotympanum is very often in certain pathologies approached from behind. Approach from behind. The retro-labyrinthine approach. How to approach that from behind? From medial to the facial nerve. So what are the landmarks here? Many a time pathology in the hypotympanum or the retrotympanum Even the cholesteatomas are drained from behind. And this is retrofacial approach. See this? This is the facial nerve. You keep the facial nerve as a bridge, as a lateral limit. Can you see? Hello? Yeah. Medially, your sigmoid sinus is your limit. See, this sigmoid sinus is going medially.
Yeah.
बंद हो रहा है यार.
How is the posterior semicircular canal related to
Yes, that's what I'm coming to. Posterior semicircular canal is the upper limit. Of the retrofacial approach, there are limits. The facial nerve is the lateral limit. Posterior semicircular canal is the superior limit. Jugular bulb is the inferior limit as well as medial limit. See, let me open up this space. यार बंद हो रहा है यार, उनको दूसरा दे यार. This is clogged. वो दे ना, ये दे. Yeah. See this retrofacial space? बंद है यार, suction. See this jugular sigmoid sinus continues as a jugular bulb medially. See how deep it goes. Can you see the blue lining coming? This jugular bulb is here anteriorly, jugular bulb is behind, and facial nerve bisects the jugular bulb exactly in the middle of the course of the middle of the width of the jugular bulb. See the jugular bulb in the depth as a medial limit. Can you see?
Yes.
Now facial nerve lateral limit, jugular bulb medial limit, and superiorly here is the posterior canal. See, let me remove these air cells to show you the thick bone of the posterior canal. See the thick ivory white bone. See this thick bone? This is your superior limit. This is your posterior canal here. This one is posterior canal. Respecting all these boundaries. Be careful about the jugular bulb below. Be careful about the facial nerve above. Careful about the posterior canal above. Can you see this space?
Yes.
Through which you can enter into the hypotympanum and the retrotympanum as well. Patla de. Or patli. This is retrofacial approach for everybody. And many a times we use this to remove even the cholesteatomas going in the sinus tympani. See my limits, the posterior canal above, the jugular bulb in the depth, and the facial nerve laterally. देना यार, बहुत time लगाता है.
if you have such a big space in open cavity, what are the ways of obliteration?
There are many ways. You know, nowadays variety of vascularized tissue is available around the ear. Right from the subperiosteal tissue to the muscles, variety of more than 15 flaps are available around the temporal bone to obliterate completely or partially the temporal bone. So one can use vascularized flaps now. See now I am going in this retrofacial space to enter into the hypotympanum and retrotympanum. Can you see? Protecting all vital structures. Similarly, thinning of the facial ridge anteriorly, from anteriorly. This is not bringing the facial ridge down, thinning of the facial ridge anteriorly. And one can go from here to there and widen this space, tilt your microscope, use your endoscope, and you can remove. See, the limit is the posterior canal. We are not supposed to violate the posterior canal at all. We are not supposed to damage the jugular bulb. We are not supposed to damage the fallopian canal or the facial nerve. And we have a great space through which we can work from anteriorly and posteriorly both. This approach can be used for the T2 or the stage 2 paragangliomas as well, extending to the mastoid. Can you see the jugular bulb below? The facial now laterally, the jugular bulb below, and this is the retrofacial approach. From both sides you can work and clear this area completely. See the round window here, the sinus tympani here, deep to the facial now. Sinus tympani is where? Deep to the facial now. See there? See the sinus tympani, which is deep to the facial now. And see how the sinus tympani is completely uncovered. Can you see? Completely uncovered. Though nowadays the endoscope is a big boom to visualize the sinus tympani with the angle scope, and one can clear. And see this approach from microscope. I have completely flushed the sinus tympani from both sides. Can you see very clear? So this is an amazing approach. Professor Tarabichi is going to show you the sinus tympani with the endoscope, probably the angled one, and that is going to be a amazing picture, I believe, to understand the anatomy of this hidden area. Now, what we have done so far, we have skeletonized our limits. We have skeletonized the tegmen, the sinus, the jugular bulb, the fallopian canal. We have seen the landmarks for the facial now at the stylomastoid foramen, this digastric ridge. Here in the vertical part, this posterior canal, the facial nerve is immediately lateral to the posterior canal. See this? In the second genu, tilt karna hai. See, at the second genu, the facial canal lies in the convexity of the anteromedial circumference of the lateral canal. Can you see this? Very clear? This is the pyramid which is emerging from there. So for facial canal at this area, the best landmark is the lateral canal. Here is the posterior canal, here is the digastric ridge. And for the labyrinthine segment, I will show you, is going to be the superior canal. So we'll uncover the superior canal as well later on. So now, once you focus on the labyrinth, labyrinth is the hardest bone in the body. See, let me remove all air cells around the labyrinth to make it more clearer. See, these are all perilabyrinthine cells. Once you do a subtotal petrojectomy, where you are supposed to remove each and every bit of mucosa, you have to exenterate all these cells. And this exercise can be done very well on the temporal bone. So let me show you how these perilabyrinthine cells are cleared in toto. This labyrinth is the thickest bone, and all these cells around are difficult to clear otherwise. See this? Around the semicircular canal. Now see here. See here, anterior to the sigmoid sinus. Anterior to the sigmoid sinus here. What is this? See this thin plate of the bone. This is pre-sigmoid area. This is thin plate of the bone. If I break it, I will be right into the CP angle. So in more rheumatized bones, this is one of the approach to target the CP angle structures. And that will be, since it is behind the labyrinth, it is labyrinth preserving or the hearing preservation approach. One can do vestibular neurectomy, one can do, facial decompression at the CP angle. One can do many procedures in the CP angle with hearing preservation approach by going retro-labyrinthine pre-sigmoid approach. Can you see that? You need to remove this bone. Underneath would be the dura, and if you open the dura, will be right at the CP angle. So what I have done, see, I have skeletonized the posterior canal. Is that very clear? I am clearing the perilabyrinthine area. I hope you can see the lateral and posterior canal very clear now.
Yes, very clear.
Now I am skeletonizing the supralabyrinthine area. That is close to the tegmen and the third canal which is relatively deeper. Can you see the third canal coming in the picture?
Yes, sir.
That is superior semicircular canal.
So which is the sac area? Endolymphatic sac.
That is much deeper. I will show you the endolymphatic sac, how the sac duct starts and where exactly it is located. That is even a deeper structure to the semicircular canal.
Okay.
See this, how the perilabyrinthine drilling is done. All air cells to be removed in toto and subtotal petrojectomy, skeletonizing the canal. This is the solid angle in between the three canals. Can you see? In live situation, many a time you come across a vessel through the solid angle, which is a branch of internal auditory artery. See, this is solid angle. Can you see?
Yes, sir.
I have completely skeletonized it. So this is your superior canal. Okay?
Yes, sir.
These are all supralabyrinthine cells. See that? Now, tilt kar do. Can you see the course of the facial now related to all the three canals? See how these canals are skeletonized thoroughly. How the pre-sigmoid dura is skeletonized. Now going anteriorly. I am going to remove the incus to show you further course of the facial now. The carotid artery is anteriorly here in the depth of the Eustachian tube. Now let me clear the anterior aortic a little bit more, the lateral part. See this anterior aortic? Is this magnification good for you?
Yes, sir.
Or I increase?
No, it's fine, sir.
Fine.
It's very good.
Okay. Now see the horizontal course of the facial now where it is going. See this. And image. Labyrinthine segment and superior semicircular. I will show you, madam. Once I dissect the cochlea, I will show you more better. And this is a valid question coming from your side. The reason being, the labyrinthine segment is very, very close, sub-millimetric distance from the upper basal turn of the cochlea. And you know why it is so important? Sometimes the bone is very thin or dehiscent between the labyrinthine segment and the upper basal turn of the cochlea, which I am going to show you. If that bone is dehiscent and if you pick up on the CT scan, you have to change your approach to that cochlear implantation. Otherwise, what can happen? The electrode in that region can stimulate the facial nerve and can give a very frustrating problem of facial stimulation. So if that bone is deficient, you have to use our approach differently by means of a perimodular implant, by means of many ways. Or you can switch off the electrode in that region, in that vicinity. Because otherwise that becomes so frustrating that ultimately either you have to switch off the implant or explant. Now see, this is the labyrinthine portion of the facial now, which is going to begin over here. See, this is the horizontal portion going anteriorly. Here in the floor of the aortic, this horizontal portion of the facial now takes a sharp medial and backward turn. See this, I am increasing the magnification. This is the horizontal portion. Here it takes a sharp, see the tegmen which is broken because this is the bone, not the cadaver properly. So I will show you at the superior surface of the Peter's bone here. See how the facial nerve is taking a turn and what all are related to it. Yeah, give me. वो भी side circle, side. See the immediate inferior anatomy here in the horizontal course of the temporal facial nerve. This is the horizontal course. Immediately inferior to it is a very, very, reliable anatomy. This is processus cochleariformis. What does it contain? This contains the tendon of this muscle. This is the tensor tympani muscle coming from anteriorly above the Eustachian tube. This is Eustachian tube, above that is the tensor canal, and this muscle is coming through this canal and taking a right angle turn into the processus cochleariformis. See this? See, this is the muscle per se, and I have drilled this processus cochleariformis. Can you see this? This is the stapes which has come out here. The stapes in the oval window. We'll discuss it later. So this is the canal. Now why I removed this? To show you some important anatomy here. I told you the facial nerve is going to take a turn here. Side. See important. This is the facial now, and this is taking a deeper turn here. This is labyrinthine segment. This continues as a labyrinthine segment. वो देना यार वो कुछ साइड या कुछ 10 बार मंगा साइड नाइफ. सी बहुत बड़ा है, साइड नहीं है, सर्कुलर है. See, I am going to show you something. सेक्शन बंद हो गया क्या? Section stopped. Can somebody switch on the section? Not working. Section gone. Switch on the section, please. I am waiting for the section to come. See, this is the horizontal facial now. This is turning here like this and going deeper here. This is the superior semicircular canal which is going like here, and this is the horizontal facial now coming like here. They have close relationship, and from this genu, a very small branch going anteriorly. Can you see this branch? This is GSPN. See, this is the GSPN. This goes anteriorly, intracranial, but extradural. Carotid artery below here takes an anterior turn here, genu. It goes extracranial. Both the GSPN and carotid go parallel to each other. The GSPN above and carotid below, far anteriorly at the level of the foramen lacerum. And there the crossover takes place. The intracranial GSPN goes extracranial, and the extracranial carotid becomes intracranial. Crossover. That is foramen lacerum. And there DSPN continues as median now. So, this GSPN is an important structure. GSPN here. Why I have shown GSPN? For some reason. GSPN is one of the important landmarks for the apical turn of the cochlea as well. Has a very close relationship to the apical turn of the cochlea. GSPN is an important anatomy from the middle fossa approach as well. We have done in cadavers many a time shown the cochlear implantation, retrograde implantation by middle fossa approach from above, following the GSPN. Immediately deep to GSPN is the apical turn, and then you can follow the implant from in the retrograde fashion, of which quality is described years back. And that approach initially was described by the quality to give infection-free approach for the cochlear implant. If you need to do a cochlear implant in a patient having CSOM, you can use the middle fossa approach. Nowadays, subtotal petrosectomy has replaced that approach because middle fossa is a difficult approach. So subtotal petrosectomy is a straightforward approach in CSOM patient if you really want to implant. And we have a case here for that tomorrow. Now, This is the facial nerve which is going down. So facial nerve going down, isko tilt karna. Say this, give me the drill. The relationship of the labyrinthine segment to the superior canal. Yes. This is the labyrinthine segment. This is the circumference of the superior canal here. Here. And this is the labyrinthine segment. They are closely related to each other. Once I open up the cochlea, I will show from below the labyrinthine segment and the superior canal. Okay? Now, so we have seen the facial nerve. Now I will elevate the facial nerve and resect it to go deeper. 15 minute baad. See, this is the fallopian canal and I am elevating the facial nerve from it, and I will resect it for the reason I will tell you, to go deeper. There are certain important anatomy deep to this course of the facial nerve, and we'll show you the relationship. Here in the cadaver, I can afford to resect the facial nerve to show you the detailed anatomy. देना scissors दे दिया कर, खड़ा क्या है, दे दे भाई. गुरु दे. See the facial nerve being elevated off the fallopian canal. See, if you can see the glimpse of the capillary plexus around the facial nerve. Can you see?
Yes, sir.
This facial nerve has a unique blood supply. In the sense, it is supplied by a capillary plexus all around the facial nerve. So one vessel comes from here at the first genu as a descending petrosal artery from the middle meningeal branch, which enters the fallopian canal at the first genu. And another vessel enters the fallopian canal at the second genu, at the stylomastoid foramen from the occipital artery or posterior auricular artery. And these two vessels join together and form an arcade of vessels around the facial nerve periosteum, which supply the facial nerve. That's why when you transpose the facial nerve, either anterior or posterior transposition, you elevate and you abrupt that blood supply, and patient gets some sort of facial paresis. Can you see I have elevated the facial nerve?
Yes,
And see how facial nerve is going deep from here. Absolutely deeper, perpendicular, and coming and posteriorly behind here. Can you see this? Deep to the facial nerve, here at this, deep to the fallopian canal, is a big structure deep to the, all these canals, is a very, very important structure is vestibule. Okay? We cannot see the vestibule unless we lift the facial nerve. Is that clear?
yes, sir.
Now I will cut this facial nerve here because this is a temporal bone. We cannot follow the facial nerve anymore in the parotid. So better I will cut over here and reflux the facial nerve. Reflux the facial nerve anteriorly to uncover the vestibule and further inner ear anatomy.
Can we see nerve to the stapedius taken from?
Oh, I have cut. But nerve from the stapedius tendon, as I rightly asked, it comes from the medial surface and enter the pyramid. A slender nerve which from here enter the pyramid. Okay? So I have cut this portion of the facial nerve which was coming in the way to go deeper. Can you see now?
Yes, sir.
So now we are very close to the further, uncovering the inner ear anatomy. What I am going to do is see the labyrinth. Very clear? Labyrinth is composed of three structures, by and large. Number one, pick. Labyrinth is composed of three structures: the cochlea anteriorly, this is the cochlea, vestibule in the middle, and semicircular canals behind, along with the endolymphatic duct, which I will show you later. Can you see this? This is all vestibule, the thickest bone in the body, which is formed by the petrous part of the temporal bone. Now let me uncover the vestibule and its connections and its significance to the inner ear surgical procedures. See this. Number one, these, I told you the vestibule is deeper. All these three semicircular canals enter into the vestibule by means of 5 openings. How do they? They have ampullary and non-ampullary end. This is lateral canal. Point on. See this. I am drilling the lateral canal. This is the ampullary end of the lateral canal. Can you see? Hello? Hello? And this is the non-ampullary end of the lateral canal behind. Can you see this? These two separate openings by means of which this lateral canals open into the vestibule. Two separate openings of the lateral canal. Okay? This is posterior canal. You have seen? See this. Let me open the posterior canal. Can you see the opening? This is the ampullary end of the lateral canal. This one will follow their entry into the vestibule. Okay? That is the posterior canal. Ampullary end. Similarly, close to the ampullary end of the lateral canal is the ampullary end of superior canal. Here it is. Can you see? So 1, 2, 3, 4 openings. Where is the fifth one? The non-ampullary end of the superior canal. Let me follow. See this non-ampullary end? This one. This one. It joins the non-ampullary end of. See the non-ampullary end of posterior canal here. Non-ampullary end of the superior canal here. They join each other in the depth, in the medial part. See how medially they are going. See how it is going medially. See the non-ampullary end of the superior canal going medially. And this is the non-ampullary end of the posterior canal. Going medially, they join each other to form the crus commune which open in the vestibule. See the non-ampullary end of the posterior as well as superior canal, both clear? Let me know if it is clear or not for you. And now I am see how the crus commune is forming. They join each other. See how they join each other. The non-ampullary end of the posterior canal here and the superior canal here, then join each other. This is the crus commune. Okay?
Yes, sir.
So they, 3 canals open into the vestibule by 5 openings. And vestibule has in total 8 openings. 5 are from the semicircular canals. You have seen? 6th opening is the oval window. See the stapes filling that oval window. I am removing. Can you see the 6th opening?
Yes, sir. Yes.
There are 8 openings of the vestibule. 5 are from the semicircular canal. 6th is from oval window where the stapes footplate is closing. If I remove the stapes footplate, you can see the medial wall of the vestibule. So now are the 6 openings. Where are the 7th and 8th? Let me drill away the semicircular canal. See this. I am drilling away and you see how these openings are. This is fallopian canal I am removing. The vestibule is deep to fallopian canal. And see the bigger opening. Can you see how big the vestibule is? See the huge cavity in the petrous bone. This is vestibule. Can you all see?
Yes, sir.
Very clear?
Absolutely.
So it is a cavity deeper to the fallopian canal, deep to the semicircular canal which I have uncovered now. I am removing all these semicircular canals to go further deeper. Removing all this. See, See, that is the epithelium. See, this is the ampullary end of the posterior canal, how it is leading into the vestibule. And it opens in the vestibule at the inferior end. Here, see the ampullary end. Here it opens. See this? So I am removing all this thick Peter's bone. Still 2 more openings to be shown. 2 more openings. Half an hour. Half an hour will be through. बोल दो थोड़ी मोटी देगा. Let me, we have a time constant now. Obviously we have to follow. So now quickly I will remove with a bigger burr this opening, and then we'll focus on the anatomy of the cochlear related to the cochlear implantation. So, karo. Hataओ, पंडल. So I will quickly remove all these semicircular canal. Vestibule is in front of us, and see finally, this is the crus commune. Yeah, this is the crus commune. See, forming the tunnel. See this? I am uncovering the opening of the crus commune. So this is how the labyrinthectomy is done. You have to remove all the semicircular canals along with the lining epithelium of the canal and vestibule for the deafferentiation in extreme vertigo patients who have lost the hearing. This is the, I would say, as a definitive procedure for the intractable vertigo in patients who are intractable to treatment, other treatments, and the hearing is already gone. Deafferentiation, remove the labyrinth epithelium. Now look at the 7th opening. Here in the medial wall, can you see? Yes. Hello? Yes. Here I am pushing my probe into it, very, very fine opening. You can barely pass a hair in a live situation. This is the opening. Let me see what passes through it. This is the medial wall containing endolymph. See, let me show you drilling this, and you will find a whitish duct. Can you see the whitish duct? That is the beginning of the endolymphatic duct. It is a J-shaped duct beginning here in the vestibule and then going behind and turning inferiorly. See this? This is J-shaped endolymphatic duct. And where it opens? Here in the pre-sigmoid dura. It opens in a sac. It enlarges to form a sac, which is nothing but a structure composed of 2 layers of dura. So here is the endolymphatic. Somebody was asking where the endolymphatic sac is going to be. So it is a deeper anatomy, deep to the labyrinth. Can you see? So that was the 7th opening leading to the endolymphatic sac.
Yes, sir. Yeah.
Now where is the 8th opening? The 8th one is connecting to cochlea. See this, I am tilting the bone.
Yeah.
See, we have seen the back door entry into the cochlea. This was the round window. If you remember.
Yeah.
Remember the round window opening? Can you see?
Yes, sir.
On the other side of the vestibule, can you see here? Drill. Another opening for the cochlea. Cochlea 3 turn. The scala tympani we have seen through the round window. Scala vestibuli is from the vestibule side. See this. If I open this, drill this bone, this is cochlea. Can you see here?
Yeah.
Cochlea is 3 turns, 3 tunnels The one tunnel earlier we have seen is the scala tympani. Can you see here?
Yes.
The other tunnel which starts from the vestibule. See this? Let me tilt and show you. This is scala vestibuli. Can you see?
Yes, sir.
Like owl's eye, can you see both the tunnels? In one view after tilting this bone. So, the superior one is the scala vestibuli. This is scala vestibuli. See that? The smaller ton. This is narrower and this is scala tympani, which is the bigger one. Let me show you again. Patla de. I hope it was clear.
Yes, sir.
See, this is the tilted picture. I have tilted the temporal bone from above. And what you see here, this was the round window which we opened and made this opening, this scala tympani. This is vestibule. And from floor of the vestibule, another opening leading into the cochlear, that is scala tympani, scala vestibuli. Yes. So let me drill further to show you better, to avoid any confusion. Let me drill this outer wall a little bit. Can you see the scala vestibuli better now?
Absolutely clear, sir. Yes. Clear.
Scala tympani here, scala vestibuli here.
Yeah.
And in the depth is the modulus. I had shown you the modulus from the scala tympani side. I will uncover everything, no confusion. See from the scala tympani side, this deeper anatomy is the modulus. The deep is the modulus, the bone. Now, where is the scala media? All these three turns run together from the beginning, make the basal turn, middle turn, apical turn, and end at the helicotrema. They revolve around the modulus. And this entire tube contains all the three turns. Okay? Is that clear? So,
Yes, sir.
let me remove the bone in between and show you the third tube as well. That is the scala media.
Medium.
The smaller one, the smaller tube, smallest of the all, which contain the sensory cells of the hearing. Let me remove this. Yes. Can you see something? The bigger turn, the smaller turn? Hello?
Yes, sir.
Making it more clearer for you now, yes. See both the turns
Yes. Yeah.
from this side, you can see. Added endoscope or silo endoscope going inside the turn can give you more detailed information. Now see,
Yeah.
this inferior tunnel is the scala tympani, where we intend to put our implant. Can you see?
Yes.
It is separated from the scala vestibuli by what? This medial structure here is the modulus in the depth. This is scala vestibuli, scala tympani, and in between is osseous spiral lamella. See this spiral lamella emerging from the modulus and going towards the outer wall. This is the outer wall of the promontory. Now see what happens. I will draw a diagram and show you better later. This osseous spiral lamella emerges from the modulus. This is modulus here in the depth. This is the turn which revolves around the modulus. This is the modulus here. This osseous spiral lamella emerges from modulus. Can you see?
Yes, sir.
And it goes towards the outer wall, here. And just before the outer wall, it ends. This bony lamella ends just before the outer wall. And from the edge of this lamella here, just before the outer wall, from the edge, the two membranes which are attached from the outer wall to this lamella. One inferiorly known as basilar membrane from the outer wall to edge of this lamella. And one superiorly from outer wall to this, that is Reisner's membrane. Can you see?
Yes.
And in between this, close to the outer wall, a triangular space. Here, a very small triangular space containing membrane. See the membrane. Can you see the membrane?
Yes.
This triangular space formed is known as scala media. Can you see very clear or not?
Yes. Absolutely.
Got my point? Let me draw a diagram and show you better. This is important to understand by all cochlear implant surgeons to avoid intracranial trauma. The cochlear implant is not like open the cochlea and thread the implant wherever it goes. It is going to destroy everything and then the hearing will not be optimum. So what you can do now, इसका aperture खोल दो ना कोई. Can you open the aperture? नहीं खुलता? चलो छोड़ो. Hello?
Yes.
Now see, this is the modulus inside. Try to understand. Okay?
Yes.
And this is the outer wall of the cochlea you have seen. Okay? From the modulus, the osseous spiral lamella emerges and ends just before the outer wall.
Yeah.
This is scala vestibuli, this is scala tympani. Okay? This you visualize through the round window. This is scala vestibuli, we visualize through the vestibule. Okay? And you saw the osseous spiral lamella. I had shown you the osseous spiral lamella emerging from the modulus going like this. Is that clear?
Yes.
This divides the vestibule into two cavities. The cochlea in two cavities. Okay? From the edge, just before the outer wall, this osseous spiral lamella ends and two membranes come from the outer wall to insert on this. One from above, one from below. Can you see like this?
Yes.
This is basilar membrane and this is Reisner's membrane. And this entire tube is converted into three cavities.
Yes.
This tube revolves around the modulus right from the beginning till helicatruma. Okay?
Yes.
Now, this is scala media.
Yeah.
So the inferior cavity is scala tympani where we are supposed to implant. Now suppose, I told you in the beginning, we are supposed to implant in the lumen of this cavity. If you don't make a straight shot lumen, what will happen? Your implant will, otherwise if you put through the round window directly, the implant will hit the modulus. It will curl from here and damage the osseous spiral lamella. If it damages the osseous spiral lamella, it damages the basilar membrane. And all intracochlear fluid mixes up. The scala tympani contains perilymph, which is high in sodium. Scala media contains endolymph, which is rich in potassium to generate action potential. If these fluid mixes up because of fracture of the osseous lamella and the membrane, the entire residual hearing is gone. This is so important to put implant right on in the lumen, avoiding damage to the osseous spiral lamella and these membranes. This is the key of cochlear implantation. For optimum hearing, it is not about inserting implant anywhere in the cochlea. Just open the round window and push the implant. Is a joke. Now, how the hearing is, connection is, God has formed from here. Let me show you. Hello?
Yes, sir.
So this was our scala media and this was our osseous spiral lamella. Let me magnify it and show you. This scala media and this is osseous spiral lamella. Okay?
Yes.
In the scala media on the basilar membrane, this is basilar membrane, are group of outer hair cells, okay?
Yes.
And one inner hair cell. And here is the tectorial membrane. So whenever the fluid movement happens, the action potential generated and the signal goes through the outer hair cell to the inner hair cell. And this inner hair cell fiber travels through osseous spiral lamella. From the osseous spiral lamella into the Modiolus. Got my point? So in the entire cochlear tube, this osseous spiral lamella contains the inner hair cell fiber traveling inside the Modiolus. Got my point? So in the course of this cochlear lumen, which is around 30 to 35 millimeter, there are such around 35 to 40,000 fibers run through the osseous spiral lamella, through the openings of the osseous spiral lamella into the Modiolus. Got my point?
Yes, sir.
Understood? So this is the outer sensory fiber from the inner hair cells. So they enter the Modiolus in the outer part of the Modiolus now. In the outermost part of the Modiolus, here is the cell body of this fiber. In the entire outermost part of the Modiolus is the cell body of this hair cell fiber. All these cell bodies are contained in the outermost part of the Modiolus, which is known as spiral canal of Rosenthal. What does it contain? It contains more than 35,000 cell bodies of the inner hair cell fiber. Got my point?
Yes.
And from here the axon starts. So from all 35,000 fibers in various tons of the cochlea, 3.5 tons, they axon emerge and they come in the Modiolus, in the center of the Modiolus, from where the cochlear nerve forms. Got my point?
Yes, sir.
Is that clear or not, or do I repeat it?
It's clear, sir.
In nutshell, the outer hair cell fiber run through the osseous spiral lamella, then they converge into the Modiolus. In the outer part of the Modiolus is the spiral canal of Rosenthal, which contains cell bodies of all these fibers. And from there the axon, the second order neuron starts, and all neurons from all 3 tons converge into the Modiolus to form the cochlear nerve, which is the axons of all these cell bodies. Around 35,000 fibers are contained in cochlear nerve. So let us dissect the cochlea and see how these tons are all around the Modiolus, and how the Modiolus is formed, and how at the base of the Modiolus the cochlear nerve is formed, to finish this dissection. Okay?
Yes, sir.
I hope you are oriented what I explained.
Yes, sir. Absolutely clear.
So let us get back to the dissection part. Professor Tarabichi, you must be bored. Looks like sleeping, huh? Not really? Now see both the tons together. Can you?
Yeah.
Now, let us see how the cochlea turns all around. This tube containing 3 tons. Again, I repeat, this is the cochlear tube which contains 3 tons, and this revolves around the Modiolus. Let's see how it revolves. Give me the drill. So we'll uncover and see how this cochlea is connected to the vestibule by vestibular aqueduct. A vestibular turn, that is scala vestibuli. So now, I will drill the promontory to uncover. बंद है यार सेक्शन, चालू होते ही. See this. See anteriorly in the floor of the Eustachian tube is the carotid artery here. So this carotid is very close to cochlea anteriorly. Let me uncover the carotid. Sometimes it is the wall between the carotid and the cochlea is distant, and we have reports where people have by mistake implanted in the carotid canal, which is a disaster. See the carotid artery there? This is the carotid artery wall, blue color, and this is the cochlea which I am uncovering. This, see this is outermost, this is scala media. See this membrane. Hello? Can you see the scala media? This is basilar membrane. So let me uncover this tube. This is the scala media. I'm opening up the tube. Scala vestibuli here, scala tympani here. Now, as we progress here from here, basal ton, the scala tympani, which is larger structure here, it becomes narrow and narrower as it goes further. Scala vestibuli, which is a narrow structure here, it becomes bigger and bigger as courses towards the anterior end. Can you see? So these cochlear lumens have various, changes in dimension and, angles. See all the three tubes. And here in the depth is the modulus, okay? I will show you the modulus later, open it. So I am going around the modulus now. And drill this basal ton. When this drilling is required in a live situation, in patients of labyrinthine sclerosis, labyrinthine ossificans, we have done couple of implants in labyrinthine ossificans, and where we always mention the subtotal petrosectomy gives widest exposure like what we have now is the need. If you try to do this kind of, drill out through the narrow posterior tympanotomy, you can imagine how close the carotid is, one can even damage the carotid. So to stay on safer side and to do a complete drill out, subtotal petrosectomy is the best approach. See how the tons are going further. Can you see?
Yes, sir.
Now let me thread my implant. I have a dummy implant. See how it curves all around the modulus. Next 10-15 minutes we'll be through. Hello?
Yes, mobile, yes.
Satish, just the last for 5 minutes.
Yes, please.
Yeah. So, you can see,
Wait, let him do. पानी दो. बस पेप्सी या कोल्ड ड्रिंक आ सकती है कोई? कोक या पेप्सी?
Yes, sir.
Hello, Dr. Satish Jain, you are around?
Hello.
We are with you.
Okay, sir. So what I was showing, you see the basal ton with the upper story and lower story. Can you see?
Yes.
Now we have reached to the anterior part of the basal ton, anterior limit of the basal ton, from where it starts further upper ton. Can you see?
Yeah.
Now if I put an implant here at this stage, see if I push an implant here, if it goes in the lumen, it should follow the lumen, actually. कर दो. A very soft electrode. What I want to show is, you can see how it follows the lumen. See, I have placed in the lumen here.
Yeah.
हिलाए मत गुरु. See, if you are not at the beginning, if one damage the osseous spiral lamella, the implant can easily go in the upper story.
Yeah.
And that's a disaster. Now, leaving the implant here, let me dissect the cochlea. Yes. Now, from here the implant start ascending. This is ascending basal turn, which continues as a second turn and around the modulus, and then continues as a apical turn. Okay?
Yes.
So where is the second turn and apical turn? Let me give you landmark. Isse patli de.
Towards the GSC.
The second turn landmark, the best landmark, where the ascending turn becomes second turn, is a fraction of millimeter anterior to the spherical recess of the vestibule. See, this is the spherical recess of the vestibule. Anteriorly, where the saccule is there. This is the saccular mucosa. Immediately anterior to it is going to be the ascending second turn or a descending basal turn. Let me show you. अरे पतली दे यार, क्या देता है यार. So I am going to show you the second turn very soon. The modulus is here. We are not going to disturb the modulus. इसको पकड़ टेबल को. See here, anterior to the vestibule. This you can say just below the processus cochleariformis, which I have removed. Can you see the where I am in? This is the second turn. This is the beginning of the. This is the beginning of the second turn, and we can see the implant inside. Let me drill away this bone to show you better. वो सेक्शन बहुत मोटा है यार. इतना हिलाता है टेबल यार. Can somebody hold the table? Can somebody hold the table? It is moving too much. एक जगह पकड़ लो इसको यूं, ये यूं. कहीं पे भी है ना, कर लोगे. हेलो.
Yes, yes, I hear you.
We have opened the second turn, and in the center again you can see the modulus. Here in the center is the modulus. See that? This is your implant, which has gone inside from here. Very soft. This has to be threaded before drilling the cochlea. Anyway, my implant is coming here. Oh, there. Right angle. Implant is coming here. Can you see the implant?
Yes.
See the implant?
Yes, sir.
And if I further push it, it will go around the second turn to reach the apical turn. Now let me open up the second turn thoroughly and the ascending basal turn. And you will see it goes around the modulus. पानी डाल यार, मजाक मत कर.
When you have a condition like labyrinthatic occipital
Yeah.
What landmarks do you take into consideration while treating?
Yeah. Number one, your point is valid. Labyrinthine ossificans is such a frustrating condition. Sometimes you don't find any single landmark. It is difficult to identify the round window which becomes part of the labyrinth ossificans. See the second turn. Now I am following it up with the descending basal turn, where the facial nerve comes in the closest proximity I told you. See the implant in place in the second turn?
Yes, yes.
यूं करो, इसको tilt करना, चढ़ो यूं. See how the implant is coming in the second turn.
Yes, yes.
Amazing 3D work, sir.
And see here, this is the descending basal turn, okay?
Yeah.
I wanted to show you the relationship of this implant to the facial nerve. Very close to the labyrinthine segment of the facial nerve. See, this is the labyrinthine segment of the facial nerve.
Yes. Center.
This is the labyrinthine segment of the facial nerve from inside the cochlea, you can see.
Yeah.
From inside the cochlear side. See this?
Yes, sir. Yes, sir.
And here is the implant. See the basal turn. This thin bone is separating where my burr point is. The implant from the facial nerve. Can you see?
Yes, sir.
This is the labyrinthine portion of the facial nerve. Okay?
Yes, sir. Very clear.
Now, patli forceps nahi hai kya? This implant is going around the modulus here again. See, in the basal turn, this implant is around the modulus. The modulus is here. Here in the second turn, again it is around the modulus. So modulus is directed superiorly and anteriorly. See the implant? And in the center is the modulus. See, this center is the modulus.
Yeah.
This center is the modulus.
Yes, sir.
Now, where is the apical turn? This implant goes from here, up here. This is ascending second turn. And then it comes here as the apical turn. See here? This is the GSPN. Can you see the origin of GSPN?
Yeah.
Just underneath the origin of the GSPN here. Just underneath the origin of GSPN, that is the apical turn. That is the apical turn. Can you see?
Yes, sir.
In middle cranial fossa approach, you find the GSPN, find the apical turn, and then one can do the retrograde implantation. You can find the basal turn and can do a regular implantation. So, basal turn, which I have already drilled away, middle turn and the apical, they are oriented antero-superiorly like this and remains underneath the facial nerve, and this is the labyrinthine segment. Can you see?
Yes, sir.
Now, let me remove this implant and drill away this further this part of the cochlea. To show you, see the modulus in the center. Can you see? वो देख कटिंग दे वो वाली पतली वाली जो चल रही थी ना. Yes. Now let me remove the scalar walls to uncover the modulus completely. How the modulus and how the turns all around. Modiolus is the central core. So what happens, you ask about the ossificans. You know how the ossificans starts. Ossificans starts because of the spread of infection from the subarachnoid space to the cochlea because of pneumococcal bacterial meningitis.
Okay.
Now how the subarachnoid space is connected to the cochlea? To the cochlear aqueduct.
Yeah.
So the first inflammation starts, the ossificant starts close to the round window where the cochlear aqueduct opens.
Okay.
If you are lucky enough to found a patient and diagnose as a labyrinthine ossificans because of post-pneumococcal meningitis, if you are following the patient, an implantation is required because of the profound hearing loss. One should do earliest, otherwise it will obliterate the lumen. So initial cases requires only drill out of the scala tympani of the basal tongue. If it progresses further, ossificans, it extends to involve the entire scala tympani of the basal tongue. Then you need a complete drill out of the scala tympani of the basal tongue. And if it is completely ossified and you don't get a lumen, you can drill out the vestibule and pass the implant through the scala vestibuli. Though the scala vestibuli is farther from the hearing cells which are needed to be stimulated, the results are inferior, but still in that grave situation of ossificans, one can still stimulate the hearing. So that requires a scala vestibuli insertion. If the ossificans is further progressive and involve the entire basal tongue, scala vestibuli and cochlea both, tympani both, one can do the middle tongue cochleostomy like I did. If the part of the middle tongue is also ossified, part of the basal tongue also ossified, you can use multiple array implant. One array you can implant from the apical tongue, one from the basal tongue, one from the middle tongue. So whatever number of hearing, sensory epithelium is stimulated is a gain for the patient. So many times we have to choose a multiple array implant to stimulate maximum possible. Because ossificans is such a frustrating problem, it becomes so difficult to identify a lumen in extensive ossification cases. So
Minimum number of electrodes should be inserted to get the optimal response.
yeah, optimum response should at least involve the electrode stimulating the hearing frequencies. Means around 1000 to 4000 frequency. So the maximum stimulation occurs when the stimulation is given through the middle tongue. The basal tongue stimulation stimulates the higher frequencies. We need the speech frequency stimulation between 1000 to 4000. That coverage is maximum through the middle tongue stimulation. So even in the complete basal tongue ossification, if you do a good basal tongue insertion and stimulation, the hearing can be very good. Now, हाँ बस 5-7 मिनट अरे यार देख माइक्रोस्कोप now I am drilling away all the scalar walls, all the outer walls of the cochlea to uncover the Modiolus. Every time I am saying the Modiolus is in the center, let us uncover the Modiolus. पतली देना. Can you see the turns of the cochlea?
Yes, sir. Yes, sir.
See all the 3 stories, triple story structure. Straight probe. See the triple story.
Yes, sir.
In the ground floor is the scala tympani here.
Yes.
This is osseous spiral lamella, this is the basilar membrane, and this is the upper story.
Yeah. Yeah.
In the middle floor, this is the scala tympani and this is the scala vestibuli. in the upper story, apical turn. Can you see the scala here in the apical turn? So triple story structure. Let me uncover more. See how complex is the cochlea.
Total three-dimensional user.
I am removing more scalar partitions. I'm completely uncovering the modulus now. You will never forget where the modulus is situated and how this tube is around the modulus all around. Now see better. See now? Better picture?
Yeah. Now can we put the implant and see again?
Yeah, see, it is the open structure. The implant is not going to follow the turns now. Everything open now. We can put a rigid fiber like nylon if you have.
Yeah.
See this? This is the basal turn.
Yeah.
The fiber, the electrode goes around the modulus. This is modulus.
Yeah.
And comes out here around the modulus. This is the upper basal turn, descending basal turn.
Yes.
And here it becomes the descending middle turn starts. Then the electrode goes in the middle turn around this. Can you see?
Yeah.
And here comes out of the apical turn here. This is apical turn. This is apical turn. So if I remove this modulus, see this is the modulus of the apical turn. Modulus of the apical turn, modulus of the basal middle turn and modulus of the basal turn here. This modulus is like ice cream cone structure. Can you see?
Yes.
Directed anterosuperiorly and see all around it, apical turn, middle turn and the basal turn, all around. Ascending basal turn, descending basal turn, ascending middle turn, descending middle turn, and this is ascending apical turn. Can you see all?
Yeah. Yes, very well.
Now, I told you the fibers through the osseous spiral lamella, they come into the modulus. See, this modulus is what? This contains a porous bone. This contains the porous bone, and this contains all the fibers from all the turns. Can you see?
Yes.
If I open up this modulus, you will see how the cochlear nerve is formed. So, the fibers from the basal turn, they go horizontally into the core of the modulus. Fibers from the middle turn, they go little oblique into the core of modulus. And fibers from the apical turn, they come vertically descending in the core of modulus. Can you see the direction? Can you imagine?
Yes.
So, if in implantation, our aim is to stimulate the sensory cells. Got my point? So, fibers from the horizontal turn come here, middle turn come obliquely here, and the apical turn obliquely down. So, in order to stimulate all fibers, you are not supposed to reach or extend your implant to the apical turn. No need, because apical turn is very narrow. If you try to push your implant through the narrow turn, it will destroy everything. It will destroy the mucosa. And since the apical turn neurons descend in the basal turn into the modulus, if your implant goes like this, 360 degree and 90 degree more, 450 degree, it covers and stimulates all the entire nerve endings without inserting into the apical turn. Got my point?
Yes.
Our philosophy is not to stimulate, not to thread the entire cochlear 720 degree. We are not supposed to thread to the apical turn, otherwise we are going to give more damage than benefit.
Yes.
So, in order to give optimal stimulation and minimal damage, your implant insertion should be 360 degree and 90 more. 450 degree covers everything. 5 minutes. 450 degree will give adequate stimulation without inserting the implant right to the helicotrema. Got my point? So, rather than the 35 millimeter long cochlear tube, maximum stimulation can be achieved by 24 millimeter insertion. There is no point going beyond 24 because the scala is very narrow. You are going to give more damage. And fibers from the apical tongue, they descend towards the middle tongue to go into the modulus. So they are stimulated equally by a 450 degree insertion. Got my point?
Yes. And how we ensure that the electrodes remain closer to the modulus than the outer wall?
Yes. So, number one, why you want electrode to be closer to the modulus all the time? It can damage the modulus if you try to do. All modular hugging implants, they got disrepute because of damage to the modulus. They have an inner stellate to keep them close, adherent to the modulus. If you try to pull it out, it will completely damage the modulus. It cannot come out without that. So the soft implants are the need of the time, which stimulate the nerve ending. You are not supposed to stimulate the modulus. You can stimulate the basilar membrane outside the wall. The nerve endings are there also.
Okay.
So you are not supposed to stimulate modulus all the time. If you try to put modulus sucking implant, you can find more damage. So nowadays, if you ask me, my indication for modulus sucking implant is in otosclerosis patients. The reason being, in otosclerosis, the bone becomes hypodense. The cochlear, the labyrinthine bone is replaced by the soft bone. It becomes more conducive to current. So in otosclerotic bones, if you stimulate the implant, the close lying facial nerve is easily stimulated because the current spreads through the hypodense bone, that is more softer bone, otosclerotic bone, to the facial nerve more easily. And that's why, to keep more distance, we want the implant away from the facial nerve and close to the modulus to prevent facial stimulation. That's the only indication for me for modulus hugging implants in the present scenario. Now last point, because our case is getting ready, that's the cochlear implant itself. I am going to uncover the modulus completely now. See this? And show you the beginning of the cochlear nerve at the lateral end of the intra-auditory meatus. अरे क्या हो जाता है इसको यार? बंद आना. सेक्शन बंद. चल तो रहा है यार. हाँ. See now, I am uncovering the modulus of the basal tongue now. Can you see? Hello? Hello?
Yes, sir.
This is the modulus of the basal tongue as well. I have opened and see what is happening. And see what is there. These nerve fibers coming in the modulus. See this? Yeah. Suction they are. Don't do this. Suction बंद है गुरु. बहुत मोटा है. Yes. Yeah. What? See this?
Yes, sir.
This is the modulus, and from here, what is happening? See, the fibers pass through the modulus, and this is the intra-auditory canal which I have opened.
Yes, sir.
Can see these fibers continue as a white nerve.
Yes. Very.
That is the beginning of the cochlear nerve.
Yes.
Can you see the cochlear nerve in front of you?
Yes, sir. Absolutely clear.
And how the cochlear nerve is formed? Here at the modulus. See this? I am removing the bone of the modulus, this cribriform bone. And this is the beginning of the cochlear nerve. In the base of the cochlea. Can you see?
Yeah. Yeah.
So all these fibers have made this cochlear nerve. This cochlear nerve begins here.
Yes.
So I have removed the modulus laterally. And see, this is the beginning of the cochlear nerve in the base of the cochlea.
Yeah.
See the base of the cochlea and beginning of the intra-auditory meatus. Can you see all?
Yes, sir. Yes, sir.
So this is beginning of the cochlear nerve. These are all cochlea which I have drilled out. The modulus I have drilled, and in the base of the modulus is the beginning of the cochlear nerve. Very clear?
Yes, sir.
This is the intra-auditory meatus from where cochlear nerve is going in this centimeter long intra-auditory meatus. See this?
Yes, sir.
Clear? So this is about the anatomy of the this area here at the base of the cochlea where the cochlear nerve begins. See this? This is known as cochlear aperture.
Yeah.
So this is the cochlear aperture. This is the cochlear aperture
Yeah.
through which the cochlear nerve is passing into the intra-auditory meatus. And see, each and every fiber passes through this cribriform bone separately. So there is a porous bone, foramens of that bone through which the cochlear nerve fibers passes through this modulus into the cochlear nerve, forming the cochlear nerve.
Yes, sir.
That is the cochlea. So we have completely destroyed the cochlea. See this?
Yes. Yes, sir.
Completely destroyed the cochlea. See, remove this porous bone. See the cochlear area.
Yes.
And what is there in the base of the cochlea is the beginning of the cochlear nerve. This is the cochlear nerve. Any questions before we move on to the live session? Hello?
The congenital anomalous here.
Yeah.
The approach for brainstem implants.
Brainstem implants are indicated when the basic functioning unit for the cochlear implant is not existing or not available. What do I mean? What do we need for the cochlear implant to work optimum? A basic functioning unit which consists of a fluid-filled cochlea and an intact cochlear nerve. If this basic unit is available, you can do cochlear implant, a successful cochlear implant. If in any given situation, if this basic functioning unit is not available, not functioning, for example, in Michel's aplasia, there is no cochlea, no vestibule. Where will you insert the implant? The basic requirement is a fluid-filled lumen, an intact cochlear nerve. So any anomaly affecting either of these two rules out the possibility of cochlear implant, and then you have to do a brainstem implant, stimulating the vestibular nuclei at the brainstem. So, like labyrinthine ossificans, if it is completely ossified, no lumen, no implant possible, no implant working, even if you try to implant, then you have to do a brainstem implant. So basic functioning unit should be there, intact cochlear nerve and fluid-filled cochlea. If this is available and patient has a profound sensory neural hearing loss, you can rehabilitate with a cochlear implant. For example, many a times we do after extensive glomus tumor, paraganglioma, glomus jugular resections. If the cochlea is spared, 8th cranial nerve is spared, the cochlear nerve. Patient has a profound loss. Even after the massive paraganglioma resection, you can put a cochlear implant. After vestibular schwannoma resection, if you have a limited schwannoma given profound loss, yet you can remove the schwannoma preserving the cochlear nerve. And cochlea is already intact, you can still implant. So after, understanding this anatomy and the success of the cochlear implant and the availability of introduction of this subtotal pterygotomy approach, any given patient with a profound sensory neural hearing loss, even after most major skull base resections, If this basic functioning unit is intact, still you can rehabilitate the hearing by means of a cochlear implant.
Yes. Yes. Sir, excellent demonstration. We all enjoyed, particularly the anatomy of the cochlea. It was wonderful.
Thank you. Big thanks to the DY Patil team for making this happen and for wonderful assistance, and the availability of the bone equipments and everything is fantastic, seamless. Thank you so much once again, and we move forward. Thank you. Let's see.